And next we have Dr. Monique Chireau. Again, in addition to being an assistant professor at Duke, she also is a staff gynecologist at the Durham Veteran Administration Medical Center. Her work is not just academic, as the Attorney General said. We're dealing with issues, obviously, of real people's lives and concerns and pains and struggles, and medical doctor knows that well. So please, thank you.
It's a real pleasure for me to be here, an honor actually. No other situation where an obstetrician will be as comfortable in a group of lawyers, I might say. But I'd like to talk today very much in harmony with a lot that has previously been said about the risks of abortion, and then expand possibly to some other areas. I am very much aware of the impact of abortion as a practicing obstetrician. I do not do them, I've never done them, but I was forced to deliver second and third trimester abortions during my training. So I know what I'm talking about with that area, as well as caring for women who had abortions and presented, were told to go to the emergency room, and who were critically ill and needed surgery. And I'll talk about that a bit more. So next slide. So, of course, the justice's decision has given rise to a number of unintended consequences, and many of these have shaped the discourse in reproductive health. Next slide, please. I have quite a bit of ground to cover, so fasten your seatbelts. And so one of the things I want to discuss is the need to evaluate some of the medical and scientific evidence as the continuing debate about Roe evolves. One of the things that's been very clearly set forth is the states have a compelling interest in maternal health. This is for a number of reasons, and this is coming from the perspective of an obstetrician who does do some legislative work. Pregnant women, and by extension unborn children, are extraordinarily vulnerable. They're vulnerable physically, emotionally, and mentally. They're easily victimized, and then, of course, death, injury, and disability of a pregnant woman or recently postpartum woman is a devastating situation for the community. And finally, for the bottom line, netted out folks, pregnancy complications are costly. They're very costly. So this is a quick, thank you, that was good. This is CDC's most recent morbidity and mortality report on abortion surveillance. One of the reasons that I bring this up fairly frequently when I'm talking about abortion is that, number one, abortions are slowly dropping, okay, especially if you look at different, whether you look at the numbers, the rates, or the ratios, they are decreasing. And in addition, if you look at the proportion of abortions and the distribution by age groups, this is changing as well. What this slide is showing is that the highest rates of highest abortion ratios are in the less than 15-year-old age group, which is very striking. Why is that striking? For several reasons. One of the most important reasons is that a high percentage of these pregnancies are statutory rape. The person who has made this young woman pregnant is 7 years or older. They're involved in trafficking, they're involved in prostitution, they're involved in molestation. So that's a very, very important statistic. In addition, you can see that as women become older, they're less likely. But again, you have this big spike in the 20 to 24-year-old age group. Why is this important? Again, who should we be targeting our message to give some insight? I'm not sure how effectively we can target to the under 15 group simply on the face of it, but we need to be thinking about that. Next slide. This is the percent distribution of gestational age. Now, again, this is extremely important. The white bars at the top are abortions that are performed at greater than 13 weeks gestation. So again, you can see those are concentrated in the younger than 15-year-old age group, and also in the 15 to 19-year-old age group. Why? Because there's often a reason why these girls, or the person who got them pregnant, hide their pregnancies. And so therefore, this is the group of women that is most likely to experience morbidity and mortality from late abortion, is in the younger age ranges. Go ahead. The purpose of this slide is to make a point, and again, for people involved at the state level, our abortion surveillance, abortion statistics are woefully inadequate, okay? If you look over here, it says that Alaska, California, Louisiana, Maryland, New Hampshire, and West Virginia did not report abortions during the entire decade the CDC has been collecting data, or for specific years within the decade. California alone is an enormous, it's got to be, we have no idea what's going on with abortion in California. So this is something to work at the state level, is to improve surveillance, yes. And then, of course, we basically have two ways of estimating abortion incidence in the United States. One is CDC data, one is from Alan Guttmacher. Go ahead. So if you look at the sources of abortion data, as I mentioned, Alan Guttmacher, AGI, is a source of data. I'm not really happy to have to look at their data, but anyway. But they only collect data from 95 facilities. But one of the things that this does is to help us to understand why women have abortion. So in 2008, which was the last year that they collected data, the majority of women who had abortions were in their 20s in this particular study. Now again, CDC data shows us something differently. It shows that the greatest numbers of abortions are in younger women. The overwhelming majority, 85% are unmarried, 29% were cohabiting, about half had been in a relationship for a year long with a man who made them pregnant, 42% of women were poor. Women who were married and had a religious affiliation were less likely to have abortion. Also, interestingly enough, most women paid for their abortion out of pocket. Even if they had private insurance, even if they had Medicaid, they paid for their abortion out of pocket. Next slide. Okay, so at present, approximately 1.3 million abortions are performed in the United States. It's one of the most commonly performed procedures in the United States. I'd like to talk a bit about the abortion, epidemiology of abortion outcomes. This has already been discussed a little bit, so I'll kind of fly through this really quickly. Maternal morbidity, infection, bleeding, uterine perforation. As I mentioned, I once had a case where a woman rolled into the emergency room with perforated uterus and bowel injury and was in the hospital for 2 weeks and was extremely ill. And I called the abortionist to confront him. And I said, you knew that you perforated her at the time that you did her abortion. You knew this. And he said, well, and he just got very frantic and started saying, well, you know, she was moving. I said, no, this is a procedure that needed to be done under general anesthesia. There is no excuse for this. And there's no excuse for the fact that you did not take care of her. You told her, you dumped her in the emergency room. And that was wrong. And so to his credit, he said, I shouldn't have done that. And he kind of went on and on. But again, this is a major issue, which is that unrecognized injuries occur, especially in late-term abortions. Unrecognized injuries occur, and these women are not detected as having abortion-related morbidity because their outcome occurs 2 to 3 days after the procedure. Go ahead. And of course, we heard about mortality. Long-term complications, these are a few, and I'm going to go into these in a bit more detail. Keep going. So one of the issues, and I think I may have talked about this in the past, some of you may have seen this, is this is probably the best study we have about risk factors for legally induced abortion-related mortality in the United States. The study is from 2004 in the Green Journal. This will never be replicated at this point in time, but it's the best data that we have. Keep going. This shows by state. If you're ever interested in looking at the study, it's Bartlett et al., 2004. And it goes state by state and looked at the number of abortions and the mortality rate by state. Keep going. It also looks at, now this is mortality. This is not morbidity. This is women who die from having an abortion. And you can see again, the abortion rate, the mortality rate increases dramatically with gestational age. In other words, the more pregnant a woman is, the more complicated the procedure becomes. Keep going. And then this again is showing again the mortality rate in first trimester abortion at 8 to 10 weeks is about 0.1 to 0.2 in the second trimester, and then again 8.9 mortality rate of 8.9 per 100,000. Okay, that's approaching. That's in addition to the other complications that occur, such as fever, infection, so on and so forth. And so it probably underestimates abortion mortality. Why? Because women may not die within the first couple of weeks after having an abortion. They may have a prolonged course and die in the hospital or outside the hospital, and the documentation of the cause of death is infection or there's some other cause. However, this study did suggest that there's a 76-fold increase in mortality, again, not morbidity, dying from an abortion between an elective procedure between early and late abortion. Or to look at it another way, for every week, additional week of gestation that an abortion is performed at, the risk of death increases by almost 40% for every week, okay? And of course, this is not true for pregnancy. So when people make this sort of erroneous comparison between pregnancy-related mortality and abortion-related mortality, the risk of death from pregnancy does not increase weekly. It just doesn't. It just doesn't. Keep going. And so, keep going. We talked about this. Keep going. I mentioned this is another study showing the complications of surgical abortion, not mortality, morbidity. So infection rate is almost 20%, okay? Damage to the uterus and cervix is about 2%, and the need for repeat procedure is 0.2 to 2%. But to a surgeon, if you have procedural risks that are greater than about 2 to 5%, that's of concern. Keep going. And that was mentioning medical abortion. So of course, abortion is clearly later. Abortions at later gestational ages is clearly more dangerous. Decreasing late abortions is key to decreasing morbidity and mortality. Keep going. The long-term complications of abortion are quite important, especially as we're considering issues like informed consent and the state's ability to regulate and protect maternal health. In many women who are, especially women in the younger age range, they are infected with sexually transmitted disease such as gonorrhea and chlamydia, and often develop pelvic infections following an abortion. Antibiotics are not routinely given necessarily during abortion procedures. And another complication that I see in practice is chronic pain. And when I have women with chronic pain, one of the questions I ask them is, have you had an abortion? Keep going. And then, of course, pelvic adhesions occur when uterine perforation happens or as a result of infection following abortion. Keep going, keep going. And I was mentioning chronic pain. Okay, keep going. And this is a very interesting study from Scandinavia looking at immediate complications after medical versus surgical termination of pregnancy. Now, when medical abortion or the abortion pill, or various names for it, was introduced, it was seen as kind of the solution to the problem of surgical abortion. In other words, abortion, I think there was a cover story in Time or Newsweek that says, abortion is now truly a matter that's strictly between a woman and her provider. Well, just as a side note, what's very interesting with medical abortion is that with surgical abortion, a woman could look at the experience of abortion and say, yes, someone did this abortion to me. She may have PTSD as a result of, and one thing that women describe with their PTSD is it's activated by things like hearing a vacuum cleaner that reactivates the experience, okay? With medical abortion, the woman is now the perpetrator of the death of her fetus. And that has an entirely different psychological impact, okay? In addition, for most medical abortions, she completes her abortion at home. And so she actually experiences the process of delivering or of miscarrying, knowing that she was the one that brought it about. Okay, so go ahead. So this is looking at, again, complications, and again, comparing the complications, the risk of complications between medical and surgical abortion. So for example, on the left side, hemorrhage, in the middle, infection. And again, what you can see is that the further for gestational age, the further along the gestational age, the more higher likelihood there is of complications, even with medical abortion. Keep going. And this is a direct comparison between medical and surgical abortion of the types of complications that can occur. What you see is that medical abortion is much more likely to cause severe hemorrhage. And again, because when the woman finally aborts, she is at home. She is not in a physician's office. She's not in an emergency room. She's not in a clinic. So keep going. And then another complication that is worth mentioning here, I think, is the fact that induced abortion in a first pregnancy has increased the risk of preterm birth. Now, my college, the American College of OBGYN, will not touch this with a 10-foot pole. They will not touch this. And there's a couple of reasons. One is that they say, well, there's not enough evidence, which is really not true. The second is that abortion is highly profitable. highly profitable. I once met a gentleman who was the premier abortionist in Cambridge, Massachusetts, and he was a millionaire several times over. So yeah, our hands are bloody, okay, our hands are bloody, and I'm ashamed of that, but they really don't want to discuss this. An important sort of sidebar to this is that African American women are 3 times more likely to undergo abortion than women of European extraction in the United States. The rate of preterm birth is approximately 3 to 5 times higher in African American women. So, next slide. And this is looking at reproductive outcomes following induced abortion. Again, keep going, this is demographics. I'll go back to the previous slide for 1 sec. And what they're looking at is that if women had an induced abortion, they were much more likely to have a miscarriage. And this Carstairs category is reflecting the fact that in England, you are assigned a social class. It's called the Carstairs categorization. And I believe that 1 is the lowest, this is really terrible, but 1 is the lowest sociodemographic category. And you are more likely to have a miscarriage if you had an abortion. And then these other data are looking at other demographics. Keep going. Keep going. Okay. And I just wanted to briefly mention this. This is another study on induced abortion and preterm birth. Most abortions were still surgical, even in Finland. They had increased odds for very preterm birth. These are the extremely premature kids below 28 weeks in all subgroups. And the risk was approximately 20% higher after 1 abortion, 70% higher after the second, and 278% higher after 3 abortions. And so you also had an increased risk for low birth weight with greater than 3 abortions. Keep on. I want to talk about breast cancer. Now, of course, in pregnancy, breast tissue begins to proliferate in preparation for lactation. The basic science is that the breast cancer risk is increased because this process is interrupted while breast tissue is still in a vulnerable state of development. Keep going. And this association has been suggested since the 1980s. Pike and Howe were some of the early researchers that looked at this. Keep going. And then the Daling study from 1994 kind of put it out there that one of the issues that we were struggling with was that the results are inconsistent. Keep going. Part of this is because breast cancer, and this is John Thorpe from UNC, who is one of my mentors and a dear colleague, says that it remains unclear whether elective abortion increases subsequent breast cancer risk. But it is clear that abortion culminates in a loss of protection, with the net effect being an increased risk. Keep going. So up to this point, I said, all right, we can't really say that abortion causes breast cancer. The association is complex. Why? Breast cancer is really probably not one disease. It's probably several diseases. It's what we, in epidemiology, we call a heterogeneous disease. Keep going. Now, that changed with the publication of this study by Wang et al. In November of last year, where what they found was that induced abortion is significantly associated with an increased risk of breast cancer among Chinese women. Why was this a good study? In China, because of the widespread application of the one-child policy, abortion is very, very common. And the one of the problems with previous studies is it's hard to sort out whether you were looking at women who had an induced abortion or a spontaneous abortion, a miscarriage. Keep going. And so because Chinese women also had low rates of breast cancer, compared with Western women, they began to wonder why over the last 20 years, cancer rates have almost doubled in parallel with the one-child policy, from 36 over 100,000 to 51 over 100,000. Keep going. And so what they found was that with a single induced abortion, there was almost a 50% increase in risk for breast cancer. Keep going. And so that doesn't establish that it causes, breast cancer is caused by abortion, but it certainly supports the association. This is, I'm running out of time here, but there's a huge literature on mental health problems. Most recently, Priscilla Coleman did a meta-analysis finding an 81% increase in mental health problems, including depression, anxiety, substance abuse. Keep going. And this is another study from last year which compared outcomes between women who had an abortion, childbirth, miscarriage, or an unplanned pregnancy. And they concluded that fetal loss exposes women to a higher risk for mental health issues than childbearing. Keep going. These are bad slides. Yeah, I know I'm running out of time here. But I did want to mention briefly the globalization of abortion, because Roe really did make it possible. As someone was saying earlier, we were one of the few countries with unrestricted access. Keep going. And I mentioned the one-child policy earlier. Some of you may have seen this slide. This is a young woman who underwent termination of pregnancy, and to humiliate her, they put her fetus next to her in the bed. Keep going. And this is another young woman with a similar situation. This is what happens every day in the United States, every day in China. Keep going. I put this slide up. I know in vitro fertilization is a little bit controversial, but it's one of the few ways that I have to express this wonder and mystery of the joining of they've captured this photograph at the moment that the sperm and egg nuclei are coming together. And one more thing that I'd like to say is that we are now entering a time where we're beginning to be able to treat Down syndrome prenatally. So you can give certain specific proteins that will, as we know, 61 to 93% of Down syndrome fetuses are aborted, specific proteins that will attenuate the effects of Down syndrome. So I think this is a very exciting time. Again, I think that the strategy of looking at abortion, having two victims, is a very important one. And I do feel that as obstetricians and people who are scientific, providing scientific advocacy, this is an area where we can make a huge difference. So, thank you.